Hi everyone, this is Mr Neel Raithatha, also known as the Wax Whisperer. Thank you for joining me in my latest video. We have here a patient who attended with bilateral, fully occluding, dark, oxidized earwax, and we're just commencing with their left ear. Because the earwax is so dry, especially the surface layer that's lateral, so towards us, in a moment going to install some olive oil medical grade ear spray, and what the olive oil does, it helps just to soften this surface, and that facilitates me in getting a suction grip. The oil also helps to lubricate the ear canal walls. When you've got dry earwax like this, the surface is somewhat like sandpaper. It's very abrasive. So as you extract this plug of wax out of the ear, quite often patients can find it's just slightly uncomfortable because of the dryness and the rubbing and friction against the ear canal wall. So again, the oil just provides a lubricant layer. I've just managed to get a suction grip here, and it's quite a substantial piece of earwax. However, there's still some more, and this wax is lodged quite medially towards the eardrum. And you can see that oil has already penetrated this. Despite that, it's quite tricky to remove. So I've managed to get a suction grip here, but because of the curvature of the ear canal, you can see the ear canal veers off to the left, and it's lodged in the front part of the ear canal near the eardrum, what we call the anterior recess. So I've just stretched the ear open. You can see the left-hand side of the ear canal now. This wax plug extends all the way into that corner to the left, and it's lodged. As such, I decided to revert to some forceps. You can see there's just a piece of wax just to the right here where I can latch onto. I've got to be careful with the bottom jaw, because that's so close to making contact with the back part of the ear canal. Now, despite getting a grip, it was just, as you can see, it was just pincing away at the wax. It wasn't really effective, the forceps. Maybe had I not put the olive oil spray in and the wax was a bit dry, I might have been more successful in my attempts to use the forceps. So I've just reverted back to performing microsuction, and I'm just trying to roll this downwards. In actual fact, I think the forceps slightly pushed the wax plug further in. So I'm just manoeuvring this out. You can see another huge plug there. It's going to re-enter the ear, examine the eardrum. You can see that to the left again, it's more pronounced now. The patient's ear canal to the left, the anterior portion of the ear canal, there's a slight bulge just to the left there, and this wax plug was stuck beyond that bulge. Therefore, I had to maneuver it out of that narrowing. There's just some soft wax near the entrance. The eardrum's nice and healthy. So I'm just going to use a fine end suction probe here, which is just to reduce any clarinetting. Clarinetting is when you sometimes suction dead skin, the skin violently flaps at the tip of the sucker, and that emits a very loud high frequency squeal. It's not only loud for the patient, but it's also loud for myself. Just a speck of wax here and there, so I decided to just mop that up for the patient. You've got a good looking eardrum there. You can see the annulus, which is the white rim around the edge, around the eardrum. So this is the same patient, but the right ear. I immediately inserted some olive oil spray just to soften this wax. And a few more hairs at the entrance on this side. And I'm just working at the base of the ear canal. I'm just trying to lift this up. Whilst removing this wax, I can sense that it's adhered to the base of the ear canal, the floor of the ear canal. So I was just trying to lift it up there. But now I've decided just to use an ear hook just to see if I can dislodge this and break it up into little pieces, because it was quite dry. And sometimes with the ear hook, although you may not be able to remove the plug of wax, it can sometimes dislodge the wax, and you can dissect it into smaller pieces, which makes it easier to then vacuum. So you can see I've just broken that up into a little piece. I'm just going to go back in and remove that. You may have noticed on both ears, as I'm entering, there's a bit of psoriasis on the pinna, or more specifically the concha bowl. So the concha is the inside bowl of the outside part of our ear. So the flaps of cartilage that looks like satellite dishes either side of our head is called the pinna, and the central bowl is called the concha region. And this patient has got a bit of psoriasis there. It is being treated by their GP. So the majority of the occlusion's gone, just some dry wax at the roof. There is some dead skin here, so if you watch in a moment on the anterior canal walls, there's some soft wax that I thought I'll hover over, and in doing so, there's some dead skin that's ready to be shed. It's in the process of shedding itself. It started to just reveal itself and come away from the front part of the ear canal. In an ideal world, I like to leave this, but you can see it's a kind of a long tail, and there's always a possibility that skin, when the patient's talking or chewing, or if they're outdoors and there's a gush of wind, that skin can move backwards and forwards and just cause a bit of a nuisance for the patient. So I've decided just to remove this skin. You can see it's keratinized. You can see the keratin, which is the yellowy appearance. So it is dead skin. It's not the fresh skin flora. It's skin that's died already. The technical name for that skin, so it's part of the epidermis layer, but the epidermis layer is the outermost layer of skin, and it's actually got 5 membranes, and the outermost is called stratum corneum. So stratum just means layer, and corneum in Latin apparently means horny. So I'm guessing that makes reference to how these dead skin cells lay in the ears. I'm guessing they protrude upwards, and it has a horny appearance and not anything else. So I've just installed some olive oil spray here just to soften this skin, just to make it a bit easier to remove. I'm just using a fine end, so that always helps to minimize the risk of clarinetting. Fortunately, we had no clarinetting here, so I've just peeled away this dead skin. There was a bit there, but I've just left that because it's too close to the eardrum. It's just settled back on the ear canal, which is great. Just some soft wax on the posterior canal wall, so we're just going to suction that away. Now this eardrum was slightly retracted, it was slightly buckled inwards, sucked in. There's another phrase often given by patients. The top of the eardrum, the pars flaccida, which is the thinner part of the eardrum. The main body of the eardrum, we call it the pars tensa. A bit duller, the light reflex is not as obvious as the other side. So this patient has got eustachian tube dysfunction, so there's a bit of negative middle ear pressure there. I hope you enjoyed that video, guys. Take care, keep well, speak soon, bye.